You good? Hello to the computer people. Hello everyone. I'm Jonathan Ben-Zev. Thanks for coming. I hope everyone got a cookie at least on the way in, maybe some water. All right. So I'm here to talk to you about doing total joints, which people think joint, there's a lot of joints in the body. Your shoulder's a joint, your elbow's a joint. What I focus on is hip and knee replacements. So we would call that lower extremity load-bearing joints. The ankle, they don't really consider a load-bearing joint. That's a story for a different day. And then we have the title here, same day. I try to do these when somebody comes in, they sign up for a hip or a knee replacement with me. The plan, unless otherwise, is for you to come in, get your new hip or knee, and then go home and sleep in your own bed the same day. 10, 15 years ago, people would spend a week in the hospital after getting a hip or a knee. I think COVID kind of accelerated a lot of this process of how we kind of get people optimized to get in and out of the hospital. And nowadays, we, unless there's a reason not to, that's how we try and do it. Does it work? Well, that was the presentation. Thanks for coming. Is this how it works, Chris? Here, maybe I'll just do it like this. Anyone know any good jokes? Let's try now. Who do I aim it at? We did test this out like 5 minutes ago. It worked then. Maybe here? Should I just do it on the computer?
I hate to have you do that, but
that's okay. I don't mind. All right, there we go. We'll just do it that way. So here's a little roadmap of what we're going to kind of talk about today. When we're thinking about any new subject, I didn't really know exactly where to start, so I thought these are the questions people might ask. So they're the common ones, but we're going to mix up the order a little bit just because that made a little more sense to me. The first one is easy. Where? We're all in that building. So here we have 3 views of where I work. This is Pleasant Prairie Hospital. Some people call it St. Cat's. Some people call it Freighter South. It's all the same building. Down there is the surgery center. So if you sign up for surgery and you come in as an outpatient, that's what it'll look like. And that's my office. That's the Prairie Ridge Clinic. That's right behind, hello Susan. That's right behind the hospital. So if you ever come see me in the office, that's what it looks like. Just a little note on some of the orthopedic surgery that we have here at the Pleasant Prairie Hospital. So I do the hip and knee replacements. Oh boy. Okay, we'll answer him later. Some of my partners do shoulder and elbow replacements and also ankle replacements. We do trauma, so broken bones. Most commonly, somebody breaks their hip, breaks their ankle, breaks their wrist. That's probably what we would call community trauma. Arthroscopy, you have a rotator cuff repair, when people put a little camera in your shoulder and knee and do surgery that way. Sports medicine, the same thing. And I put spine surgery. Most people know what a spine is. These are my partners, Dr. El Swaf, Dr. Zacharias, Dr. Gegenheimer, and Dr. Mehdi. So if you have a problem and I can't solve it, one of these smiling gentlemen will help you guys out with it. Okay, so the what? What exactly is a total joint replacement? But let me answer this, and only raise your hand if you feel comfortable. How many people in here have a hip or a knee replacement? Okay, so you guys kind of know what it is. How many people here are curious about potentially thinking about what a hip or a knee replacement for themselves? All right, there we go. So some people come to me in the office and they think, I'm going to take out their whole knee and then put in a whole new knee, which is not exactly what it is. It's really more of a resurfacing. So what are we resurfacing? This is what arthritis looks like. So here, do I have a pointer or no? Okay, well, I'll use my finger. This is what a hip looks like. I'll try that. You don't know Vanna White? Here, if you touch it, it turns into a new hip. Okay. So hip is a ball in a socket. So here's the ball. That's part of your femur. Here's the cup. That's called the acetabulum. It's part of the pelvis. It looks like the bones are not touching right there, but really they are. That's just where the cartilage is. cartilage doesn't show up on x-ray. Cartilage is, if you ever have a chicken wing and you see the end, there's that shiny white stuff, you get the same thing on all your joints, and what let everything glide smoothly. So arthritis is when you wear away this cartilage. And that can be through the wear and tear of life. It can be from an injury, a lot of different reasons. But the cartilage, it's like taking sawdust off a 2x4. You can't really put it back on once it's gone. So as it wears away, then the bones are touching, and then people have bone-on-bone arthritis, which causes inflammation and pain and stiffness and all the things that I try to get rid of. And here's what it looks like in a knee. So let me see, it's hard to do both here. Here's your femur bone, that's in your thigh. Here's your tibia bone, and then you have the space here, and here, not so much space. So what's the replacement, the resurfacing? It's tough to do it like this. We'll keep going. So it should be all looking like this nice, shiny white cartilage, but it gets worn away for various reasons. And then what you do is you essentially, instead of just taking the whole knee out, you move the kneecap out of the way. You make very specific cuts on the ends of the bone, and you put a new metal cap kind of on here, a metal stem down in the tibia, the shin bone, and then there's a piece of plastic that goes between them. And it's like a surgical grade plastic. It's pretty good stuff. And so the bearing surface, instead of having this bone on bone, you now have metal on a plastic. Hip is a little bit different. Same thing here, kind of all worn away. You put in a new socket. There's a plastic liner inside there, except this pink thing, a lot of times we'll use a ceramic kind of in there. And basically the whole point is that you get a smooth surface. So it's not like the whole thing comes out. Does that make sense? Also, since we have a small group, if you guys have questions, just raise your hand or interrupt me. What you guys want to know is obviously more interesting than what I can tell you. So if you think of something, feel free to interrupt. Oh, so this is what they look like. These are the ones that I use. There's lots of different companies out there that make them. And so the hip replacement is 4 parts. Someone once called it a spike, which sounded a little aggressive to me, but now I kind of use that term. This spike or stem is what goes down in your femur. This cup goes into the pelvis. The plastic liner goes inside, and then the pink is the ceramic ball, so you get a nice smooth bearing. If you ever come see me in the office, I have a bunch of them, so I give you one, you can hold it, see it, what it looks like. Here's the knee. This part goes on the femur as kind of a cap. This mean-looking thing goes in your shin bone. Well, you want it to look mean because then it really bites into the bone. And then this plastic is the liner in between. There are a few ways of doing a knee where you can cement it into the bone or you can press fit it on there. If one was so clearly the best, it would just be called the way. So there's multiple different ways of doing it. I like to use this one. This rough surface, if you cut the bone perfectly plain, when the metal sits on there, over time, like 6 to 8 weeks, the bone will grow into the metal, and then it just becomes a part of your body. I prefer to do that instead of cementing because a cement, over 20, 30 years, the cement is the strongest right when you put it in. It can only get weaker. When the bone grows onto the metal and it's a part of your body, it can kind of withstand, it's a little more durable. Any questions so far?
Yeah, what type of metal that doesn't
Oh,
get rejected?
excellent question. What are they made of? Wow. Don't tell them that I asked you to ask that. So, yeah. So these implants are made out of a lot of different things. The primary metal is titanium. Titanium is a very inert metal. The porosity of kind of titanium on that rough surface is similar to kind of the spongy bone, so it can closely mimic bone. Certain companies will have kind of proprietary metal blends or ceramicized metal, and this is where the material science of it comes into play. But these are kind of the main things. Other metals you might have in there are cobalt, chrome. They all have some degree of nickel. Some people, you ever hear about some people having a metal allergy? The cells in your skin and the cells in your bone are not the same. So some people, if they have a metal allergy even on their skin, you won't necessarily have a reaction to that in their bone. But there are options for that. The polyethylene is the plastic part. You have that in hips and knees. In the lab, they cycle these on a machine millions of times, and they wear at a rate of 0.02 millimeters a year. This is probably where some of the biggest advancements have been made in the last 20, 30 years. The plastics that they used back in 70s, 80s, and 90s would wear a lot quicker, and that would cause problems. So these plastics are treated in a way to make them very long-lasting. And then this tantalum versus osteotie. Tantalum is an elemental metal that is very similar. For bone to grow to the metal, it has to have a few different characteristics. It needs to have pores, it needs to be very rigid fixation, and the pores need to be a certain size. So tantalum is pretty similar. These days, they have ways of 3D printing titanium so that they can do it that way. And we kind of talked about the ingrowth versus cementing. Does that answer your question?
Yeah.
Any other questions?
I have a big problem with my kneecap, so I don't know if you replace that, because it sure doesn't have any work.
Well, I'll tell you this. We're getting into some high-level questions here with the kneecap, but I'll touch on that. So when you, let me go back here a little bit. Oh, that's me. Okay. Okay, so you can kind of see it here. So the knee is really, they talk about it's a joint, but it's really 3 compartments. I don't have a great picture of it, but there's the inside, the outside, and where the undersurface of the kneecap touches the femur. This replacement is replacing the inside and outside parts. I can't tell from this picture whether the kneecap has been resurfaced. When we talk about resurfacing, you kind of cut off the back of the kneecap and you put on this plastic button. That is a somewhat controversial subject, whether to do that or not. A lot of the literature out there says that whether you do it or not, people do about the same. Now, if somebody is having their kneecap dislocating a lot, there are some reasons why you might do it. In general, I do not resurface the kneecap, and I do that because to do that, you have to cut away, 8 to 10 millimeters of the bone. That bone is under a lot of tension forces, and I don't know anything that gets stronger when you cut half of it away. So that's somewhat controversial. If we ever get to the point where we're talking about it, I'm more than happy to go into the details. But sometimes you resurface the kneecap, sometimes you don't. Oh, thank you. Let's see if it works. If not, I don't mind pushing it. Oh, this feels fancier though. Now I can walk around, clicking. Okay, I think we're still, what are we on right now? I think we're still on the what? Okay, so why would you get one? The biggest reason to do one of these surgeries is because you're having pain. With a hip, a lot of people have groin pain if it's truly coming from the hip joint. With a knee, you kind of have pain anywhere in your knee. You can get stiffness, it's crunchy, but the primary reason to get a surgery like this is to replace the pain. When the bones are rubbing, they become inflamed, it becomes very uncomfortable. So who is a candidate? You need to have arthritis on an x-ray, that's the first thing. So if you come to see me, we get x-rays and we talk about trying the different options. How long will it last? The thing that will wear out the fastest, if everything is done perfectly, is the plastic. The ones we are putting in today, people think can last 20 to 30 years, but they could even last longer. If we end up doing a hip or knee replacement, we see each other every year or 2 years and get x-rays just to kind of check on that. Because if there's a problem, it's a lot easier to change the plastic than to change out the whole thing. Now, if you're doing maintenance on your car, you'd rather fix the brakes than redo the whole transmission. Does that make sense? The goal of the surgery is to put a joint, not to be morbid, but you put a joint that you will die with. That's the goal. Any questions on this? Nothing? Maybe over there? No? All right. Who? Okay, now we're going to, here's what I look like in the office. I had to wear a white coat for the picture to look formal. Normally I go no coat. Today I did this, I'm giving a talk. I wanted to look nice for you guys. This is what I look like on the other part of my job. You'll see a nice Red Wings lanyard. I like to rep my hockey team. And I also always going with a bandana because I'm working hard in there and I get sweaty. Here's kind of my little fast facts elevator pitch. So I'm from Southeast Michigan, kind of a suburb of Detroit. I went to the University of Michigan. They won the national championship in football last year. I don't know how much you guys pay attention to that. No big deal. I went to medical school at this place called Wayne State. That's in downtown Detroit. Do you guys all know what residency is? Everyone ever kind of heard of this term? Yes, no? So after you finish med school, that's where you kind of get more training in whatever kind of doctor you're going to be. So I was down in St. Louis. That's where I met my wife. She's sitting right there. She likes when I put her on the hot seat. She raise her hand, stand up, maybe say something to the class. Okay, we don't have to do that. She also works here. She's an occupational therapist, so maybe you'll see her. There's also many other therapists here with us. We won't put them on blast. And then after residency, I did something called a fellowship. Fellowship you don't have to do. This is bonus training, and it's additional year in any of the subsets of orthopedic surgery. So you can do hand, spine, foot and ankle, pediatrics, trauma, tumor, sports. What I do is called adult reconstruction, but people within ortho just call it joints. So I was in Southern Illinois for that, in Springfield, Illinois. It's really more of the middle of Illinois, and there are many corn and soybean fields.
What year was that?
That was last year. So good question. So this is I started working here in September of last year, and so I was in fellowship from 2022 to 2023. So I'm new.
Not used.
Yeah, I'm very fresh. That was a good one. Any other questions about this stuff? Any of you guys ever been to Michigan? Lovely place. Okay, that's the formal. Here's the informal. So there's, here, now I'll use this. Here's Courtney up there. This was at my cousin's wedding. This is us also. We have a Great Dane. Here she is. That's Penny. More Red Wings up here. We don't have any kids yet, but I have lots of nieces and nephews. We like to mess around with them. Here I am. This Sputnik-looking thing is something we took out in Springfield, Illinois last year. Well, 2 years ago now. And then here's some things I like to do. Here I am playing hockey, and here I am snowboarding. So I like a lot of cold weather stuff, as you guys can tell. And I play at Kenosha Ice and sometimes at the Recplex. Now that I don't feel like it, but I play in what's called the Geezer League at the Recplex. So there you go. I'm at that point in my life. Any questions about these people? No? Okay. Thank you. I feel like it some days. Okay, the other part of who is the team? When you come to see me in the office, it's not just me. We've got a whole crew of people. So the first person you'll see is Rob. He is our medical assistant. He was hard at work in the office when I left to come here. Oh, another person we can put on blast. Megan is our team's PA. She's sitting right there. She's also fresh, like me. So we've got a young squad. Kelly is our nurse. She's worked at this hospital for a long time. She was a cardiac surgery nurse, and then she decided she had enough hearts and she wanted to do something cool, like orthopedic surgery. So she came over here. And Hannah, who's also here, is our joints coordinator. She's not shy. We could put her on blast if we wanted to. So she kind of runs the joints program, and we'll talk a little later. There's a class that she puts on, but there's no quizzes or tests. Very high pass rate in the class. Okay, so that's our who. Why? Okay, so that kind of gets us back to that title slide. Why is it better to go home on the same day of surgery? Here's some reasons why people think, why could I not go home? These are the most common concerns I hear about. If you guys have other ones, we'll talk about them now. So one is, I'll be hurting a lot from this big surgery. Back in the day, people used to just hit you with a lot of narcotics after surgery, which was one way of dealing with things, but as we learned, probably not the best way. So now we talk about something called multimodal pain control, where you do have some narcotics, but you also get an anti-inflammatory, a muscle relaxer, some kind of low-grade pain control that's not a narcotic. Talk about doing different types of anesthesia. Basically try and kind of control your pain from a lot of different angles. Anxiety about going home. This one is one that sometimes some people are really excited to go home on the day of surgery. Some people think they want to be in the hospital. So my first question is usually, well, what concerns do you have about going home? People think about the help they're going to have or what they will and won't be able to do. I would submit that you would probably be moving around better after the joint replacement, even in the early post-op period, than before it. But we have a long talk about getting your home ready and having people there who to help you and stuff like that. Nausea can be a reason after surgery. That's my friends in anesthesia can help with that. Physical therapy. We have everybody who's going to get a hip or a knee do some physical therapy before they even do the surgery. So they call it a prehab class. And we have found that doing that on the front end makes things a lot easier on the back end. Blood loss. That's my job. I need to make sure you don't lose too much blood. If you lose too much blood, probably not good to send you home. So far, we've been pretty good about that, but that one's on me, not you. And urinary problems, that can also be related to anesthesia. What commonly happens is they say, men are unable to go, women are unable to stop going. So there are different kind of medicines we can do to work with that. Any other things people might think about? Questions? Concerns? Yeah.
You have your hip done, what about stairs?
Good question.
You only have one bathroom and it's upstairs.
Very fair question. So they work on some stair stuff before. You are able to do the stairs. What I would say is if you are able, if in your home, for example, you say the only bathroom's upstairs, is there, like, in your case, is there also like a bedroom up there and stuff like that?
Yes.
Basically, you would try to optimize your home where you do that as little as possible. You're physically able to do it, and our talented therapists will help you figure out how to navigate stairs. And they also kind of coach you on it before. But it's a fair question. Any other thoughts? That's a good one. So the benefits of going home. Being in a hospital is not a great place to be unless you need to be in a hospital. There's lots of beeping. People will poke you with needles. They will wake you up. They will take your blood. The beeping, as I mentioned. Also, just in a hospital, you have a lower infection risk by going home. Yes, question.
When do you do it? When is it too late to do it, or is it too early to do it?
A hip replacement or a knee replacement?
Either one, you just go by pain?
Yeah, fantastic question. That's a little offshoot, but I'm fine with that. That's what we're here to do. In my opinion, I think you'll get some people, you go to see them in the office, anyone who's too excited to jump in and do surgery on you too early, I would say pump the brakes with that person. We'll get to this later, but we'll just jump ahead now. So nobody needs a hip replacement or a knee replacement. In the history of the world, no one has ever died of arthritis. So if you ever have someone tells you you need a new hip, you should politely tell them, I don't know that I need it, but it would be nice. The time to do it is when you have tried all of the non-operative things, medicine, therapy, injections, and you have to get to the point where you say, this bothers me enough that I'd be willing to do a big surgery to do something about it. The only person who can decide that is you. So when you come see me in the office, we get your x-rays, we'll do an exam, we'll look over the x-rays, we'll talk about everything. And if you're a candidate for the surgery, I tell you, you tell me when it's time. Some people say, oh, I want to do it now because in 5-10 years from now, I might not be healthy enough to do it. I think in a lot of aspects of life, it's good to be proactive about a problem. When you're talking about having a big surgery on your body, don't sign up for a problem that you may have one day. And if you do, I've done hip and knee replacements on people in their 90s. People are healthy enough to do it. The age is not something that scares me off. So it's never too late. I would say the people who do the best are the ones who were truly at their wits' end and miserable before and say, I can't live with this anymore. I've tried everything. Let's do it. Does that sort of answer it?
Yeah, I guess I'm not sure about it. It's better to when you're younger, like you said, when you're healthier.
Mine, I really have to get mine done. My knee will give out and I will be on the ground. And at my size,
Well, then you have no choice, but I'm talking about at a point where you're definitely a candidate. You wait 5 years and then it's worse.
It's a tough one. I can't make that decision for you. I can tell you what the options are.
Yes, you do. You have to decide how much pain you can handle before you do it. If it's too much pain, then it's a good time to do the operation.
Just because you have bad arthritis, you treat a person, you don't treat an x-ray. So if I see an x-ray, I will tell someone, well, your knee looks horrible. But if you're not having daily pain that interferes with your daily life, well, I said daily twice, so I guess that makes sense. If you're not having pain that interferes with your daily life and it's tolerable, my vote is live with it. But I can't feel what you're feeling. So I trust you to I'll be as upfront with you as I can, and I kind of count on you guys to be as upfront with me as you can. Okay, so back to this. You get to go home, no one's poking you with needles, there's no beeping, you sleep in your own bed, lower infection risk, and I will send you home with a bunch of different medicines, so many that I give you a little sheet that tells you what every single medicine does. Okay, who part two, the patient. We've kind of talked about this a little bit. Things to look for. When people come to me and they say they have hip pain, sometimes they'll tell me it's here, here, here. You know, the hip means different things to different people. True hip pain coming from a degenerative joint, they call it a C sign. Like you make the letter C with your hand, they say, I feel it kind of right here. People will feel it in their groin. You won't have a lot of motion. Normally I'll ask people, you have a hard time putting on socks? Because if you can't do this, hard to put on socks. Unless you have a sock putter on or taker offer that the therapists give you. They got all sorts of tricks. There's a huge amount of overlap between pain in the hip and pain coming from the low back. So if someone comes see me and they're telling me about this hip pain they have, and their x-ray doesn't look that bad, the next thing I'll do is I'll get spine x-rays and we'll examine your spine. And if I think that it's truly coming from your back, we do some therapy, and then I would send you to Dr. Mehdi, who we had his picture in the beginning. He was the one right over here. He's also fresh. We got a lot of fresh people these days. Knee arthritis. Basically, you just have a lot of knee pain. Can feel like a deep achiness and stiffness too. When really bad arthritis, people find that they can't straighten their leg out all the way. Any kind of crunchiness, sound, swelling, that can be knee arthritis. Questions here? Well, so falling, I would submit, is probably more related to muscle weakness than truly from the knee. People say their knee gives out. Usually it's their quads. So let's say somebody has really bad arthritis. Talk about their knee giving way. I would have them do therapy for a couple weeks to get that muscle stronger before surgery. You do the surgery, it's not like your muscles automatically, they don't magically get stronger. So to get the best result, you have to strengthen that leg. I got a whole bunch of exercises too. Okay, so now let's say we decide to get a knee replacement. Now what do? So this gets back to that same day stuff. There's this physician, Charles DeCook. He works down in Atlanta. He gives lots of little talks. If you ever get interested, you want to go on YouTube and look up some of his stuff. He's a very interesting guy, very smart. So I was at a conference recently, and he said, everyone is an outpatient unless you give me a reason not to. Part of doing that is that you have to do a lot more work on the front end. Sometimes people can't. If you have severe lung, liver, kidney diseases, you generally want to stay overnight. People have heart problems. I'll keep you overnight just to kind of keep an eye on you, and most people go home the next day. To go home before, you got to do a lot of work on the front end. These things that I have kind of listed down the bottom here are what I would call modifiable risk factors. Every surgery has risks. Some of them are modifiable, some of them are non-modifiable. Here's a non-modifiable risk. To put the knee replacement in, I need to cut your skin open because it's very hard to put it in without doing that. But cutting your skin open and making a wound is a risk of an infection. So that's not really modifiable. I kind of have to do it. Price of doing business. Things that are modifiable. How well controlled is your diabetes? Do you smoke? Do you not smoke? Weight, nutrition. So anything that we can modify on the front end, we do. And if that takes us longer to kind of get you ready for surgery, then it is well worth it, in my opinion. Pain medicine is one as well. Sometimes we'll see people who are they see pain management or they've been taking narcotics for a while. I'll work with your other doctors to kind of, we get a plan in place on how to taper it off before and kind of have a plan in place for after. And then this is kind of the checklist. I have you see your regular doctor, make sure you're healthy enough for surgery. I have you see the dentist. A lot of people ask me, why am I going to the dentist? There's a lot of bacteria in the mouth. So that's another modifiable risk factor. If you need teeth pulled or stuff like that, I have you do it before surgery. Some people need to see cardiology. The aforementioned Hannah's class, I went to it myself. I was coughing it up a bunch. And then the prehab, as we discussed. And I'm currently trying to modify that a little bit. Right now I was having people just do physical therapy, and I'm trying now to do a combined physical and occupational therapy in the prehab. And if you don't know what occupational therapy is, you will find out. Questions about this? Checklists, pre-op stuff? No? Other things, getting your home ready. We have a whole list in the Joints book. We spent a lot of time when I got here of making this whole book that will answer almost every question that you have. The only thing is you have to read the book. That's kind of the challenging part of it. Talks about preparing your home, having someone ready. So there's an old saying about George Washington said, if I had 10 hours to chop down a tree, I would spend the first 8 hours sharpening my axe. So to me, what that means is you spend the work to prepare. If you go in unprepared, you won't be able to do the job as well. If you live alone, I ask that you have somebody, friend, family, neighbor, who's at least available for the first 3 or 4 days just to kind of help you out with some stuff. But getting your sleeping situation, your bathroom situation, meals, all that other kind of stuff ready, those are all things that you can do on the front end. The other part that I try to do is I try to do this without general anesthesia because I think that helps get people up moving earlier. So to do that, we do what's called a spinal and sedation. Not everybody is a candidate for that. That's a whole separate talk for a different day. But if you're curious about it, we can talk about that more later. But the spinal, you are not asleep, but they also sedate you. You're not hearing the saw going and everything. Unless you want to. We can ask them to give you a low dose, just keep you awake. I'm kidding. We wouldn't do that. But not everyone is a candidate for it, but I try to do that because it gets you up and moving a little faster. Questions about any of this stuff? Here's the biggest one. You got to have a positive attitude. You have to want to go home. If you're kind of dragging your feet, you don't really want to do it. Whether you ever heard this phrase, whether you believe you can or you can't, you're right. So you have to want to be able to get up and get moving. The reason to get these surgeries are to get you moving and doing the things that you love to do. Plenty of communication before and after, and we talked about that multimodal pain control. Oh, I didn't mention, one of them is a nerve medicine. So 2 different types of pain medicine, a heavy hitter and kind of a low dose one, an anti-inflammatory, a muscle relaxer, and this nerve medicine. There's a whole list, but I make it easy for you, don't worry. Another thing that can kind of help get you moving a little faster, there are 3 ways to get to the hip. You can go from the front, the back, or the side. They all have their own advantages and disadvantages. I like to go from the front, so to kind of orient you. This is that bump on the side of your hip. Your head's up here, feet down here. Here's the right hip, here's the left hip. So the scar is kind of like right here. And when you go from the front, you don't have to cut through any muscles. You kind of swim through them. Going from the back or the side, you do have to cut through some muscles, and that's not the end of the world. But it is usually a little, people say with an anterior approach, you recover faster. And it also, you don't have the same precautions. If you ever heard of someone who got their hip done from the back, there's certain things they don't want you to do, positions you put your leg in, because it can be a risk of a dislocation. So you have a bit fewer of those when you go from the front. And here's some cool stuff that I get to use in the OR. So when you go from the front, you can use X-ray a little easier because the patient is laying flat on the bed. So everything is AI these days because it's a very trendy thing to be. But what this is it's a program that plugs into the X-ray, and as I'm putting in those components, it will tell me the exact angles I have them at, and I try to get your leg lengths as close to even as I can. I don't guarantee you that I'll get it perfect, but I guarantee you that I will try very hard and get them very close. So this is one thing that kind of helps with that. And on the knee side, there are a couple different things. People talk about robotic knees, robotic hips. A robot, I think, is very valuable in some cases if people have prior hardware, if they have big deformities, if there are specific reasons to need it. But I think for your quote-unquote run-of-the-mill arthritis hip or knee, you don't need to use a robot. But we do have one here, and I do know how to use it. And if people feel strongly about it, we can talk about that. That's over here. This other thing is a very, where's my clicker here? This is a very fancy, it's kind of like a gyroscope. You attach it when you're doing the knee, you move the hip and the knee around, and it can kind of tell you what specific angles of how to make the cuts to do that knee. I don't use it all the time, but if somebody has already a big rod in their leg, let's say they broke their femur years ago, this kind of thing can help. Questions about these? No? All right. When? This goes back to your question. You tell me. If you come to see me in the office, we'll go through everything, but the only person who gets to decide if we do this is the patient. Kind of a big responsibility, but we're meeting each other halfway. So this is what I said. Nobody really needs a new hip or knee. What I would tell some of the phrasing I use is, I would say, I think you would benefit from a hip or a knee replacement. But you will never hear me tell me you need to do it. You always have a choice. I'm a pretty conservative guy when it comes to doing surgery, so I really think it's the last option, not the first one we should jump to. One of my friends who works in Arizona says when he sees a new patient, somebody wants to jump right into surgery, he tells them, I don't kiss on the first date. So he makes them wait a minute. I've said that once or twice now. Megan can attest. Not all the time. If this is something you want to know about, come and see me. Here's at Prairie Ridge Clinic. Here's our number. I got some cards over there. And then this is what they look like. And I hope that this talk didn't leave you feeling how my dog feels 90% of the time, which is asleep on the couch. I don't know. There you go. These are real people who I did surgery on, and they love it, I think. They do. I don't know. That's all I got. I know I kept asking questions in the middle. Anything you guys can think of that I didn't go over?
How long is the post-op?
The recovery?
Dr. Ben-Zev, can you please repeat the questions for the live audience?
Yes. Hello. Which camera is the live audience? They're pointed slightly differently, so this is the one. Question was, how long is the recovery from a hip or a knee replacement? So different for either one. I will tell you that a hip is much easier to recover from than a knee. A hip replacement is more like a native hip than a knee replacement is like a native knee. And the reason for that is that a native hip is truly a ball and socket. A native knee is not just a hinge. It rotates, it translates. So the implants we have can be very close to that, but I tell you, it will never feel exactly like the knee you had when you were 25. The goal of a knee replacement is to take away the pain from the arthritis, not to make your knee feel like you did when you were kind of running around young.
I just want one at 77 that it works.
Well, that's something we can do. But the recovery on a knee, you have to do a lot of therapy on the back end after the surgery, because if you don't, it will get very stiff. And the goal is by 6 weeks, you want to be all the way straight to bending at 90 degrees. With both of them, you're walking the day of surgery. But a hip replacement is easier to recover from. Usually in anywhere from, after either I send you home with a walker. Usually people get a hip replacement, anywhere 2 to 4 weeks, they're kind of off the walker. Knee, sometimes a little longer, and a knee is just a longer recovery. I got a little sheet in the office when somebody signs up that has kind of time on one axis and how you feel on the other end, and I make sure everybody knows so they don't think I'm a liar. Say, 1 month in, we're not going to be friends. You will not be very happy with me. But it's that kind of months 2 to 6, 2 to 8, where people really kind of start to do better. But it's not like a linear recovery. It kind of looks like the stock market. On a good day for the stock market, I suppose. Yeah. Other questions? Yeah.
The joints that you use, the artificial joints, is it one size fits all?
Oh.
Everybody's different size.
Yeah. The question was whether the joints that I use are one size fits all or how I do that. So, before I do the surgery, really more on a hip than a knee, you take a picture that has a little metal ball. On the x-ray, I take a picture with a metal ball. The metal ball, I know, is 25 millimeters. That accounts for magnification of the x-ray. I import that x-ray into what's called a templating software, and I tell the software, this is what 25 millimeters looks like. I use that then to kind of, there's little overlays that I can kind of lay onto the x-ray and get a rough estimate for what the sizes I want to use, which are different for everybody. And then when you're in surgery, I'm not a slave to the template. The template says the cup should be 52 millimeters, but I have that 52 millimeter cup in there as I'm preparing it. It just doesn't feel right. That's where you get a little bit of the art, not the science of medicine. So I bump it up. So it has to do with press fitting the bone. So to do that, I need it to be exactly the right size. And there's tools in the operating room that you use. On a hip, it's kind of a feel thing, and I want to put in that stem here. Like, you can imagine these get skinnier, they're all about the same length, but they get skinnier. So as I prepare it, I basically go up bigger and bigger and bigger on the size until I feel like it gets kind of like it's stuck in the right spot. That's why they don't let anybody do this. You got to train for a long time. And then on a knee, when you're in there, there's you make your first cut on a knee, and then you put a sizer on, and that kind of helps dictate the size. And then there's different trials, and you kind of, before you put in the real components, you try the different ones out to kind of make sure you have good coverage on the bone and it fits right. That was a good one, though. Yeah?
I've heard the word hip dozens of times, and knee dozens of times, and I know dozens and dozens of people who have them all. I have not heard the word ankle.
All right. So there are such thing as an ankle replacement. True arthritis of the ankle is not as common as arthritis in your hip or knee, because when we say ankle, we think of just something that moves your foot up and down. The real ankle, in an orthopedic term, people think of it as the hind foot, which is 3 or 4 major joints. So the load is dispersed across those differently. The most common reason you would get ankle arthritis would be if you had some kind of injury that led to then a post-traumatic arthritis, meaning the injury dinged up the cartilage, maybe you got it fixed, maybe you didn't, down the road it wore away. One of Dr. Montemurro, who is in podiatry, same office building, he does the ankle replacements. So if that's what you're interested in, I'll get you sent to my friend, Dr. Montemurro. But I don't do those. Yeah. Any other ones? What about from the people who work here, which is 2/3 of the room?
Now, you talked about the surgery center. Is that where your Dr. Generali is?
Yep. So the surgery center entrance is kind of right that way. It's all connected to the hospital. I think one of the benefits, for me at least, of working here is somebody comes in even as an outpatient through the surgery center, and we have options. You know, say you can either leave through the front door and go back home, or leave the back door and go into the hospital. So it's yeah. So you can. So it's the surgery center is part of the hospital. Yeah, it's all right here.
I like this hospital. It's been around for a long time.
I like it too. Yeah.
And I like Dr. Degenheimer. He did my wrist.
We got a great team.
You do.
Yeah, especially those young guys.
Yeah. Well, for a while, I didn't like Dr. Degenheimer. You were afraid like that.
Well, I'll tell you this: if we're in a situation where one of you guys is not going to like me, I'll tell you on the front end you're not going to like. It won't be a surprise.
No, that's okay. After a while, I go back to mine.
Good.
I love all my doctors, and they're all in that building.
Mm-hmm.
So if I come to see you, I can see anyone.
Try and make it a one-stop shop.
Try.
The ankles are up on the 4th floor, though, so we'll send you up there.
And Dr. Hill, he takes care of thumbs.
Mm-hmm.
Or hands.
Yeah.
Yeah, I like that.
Good. Well, if you don't have anything else, thanks for coming out. I appreciate you guys taking the time, listening to me. And if you have anything else, come see me anytime. And thank you all as well for watching.